Welcome to the weekly neurology deep dive. Just a quick note before we start. This discussion is purely for educational purposes. There's no commercial goal here. It's really just a summary of the source material we're looking at. We absolutely recommend you read the full papers for the complete picture. Today, we're diving into something really critical for all neurologists. It's about the diagnostic performance of those commercial tissue-based assays we use for neuronal and glial autoantibodies. For suspected autoimmune encephalitis and paraneoplastic neurologic syndromes. We're drawing insights from an editorial and a specific research article in neurology, neuroimmunology, and neuroinflammation.
And these conditions, they're notoriously challenging to diagnose, aren't they?
Yeah.
The symptoms can overlap so much with other things, and they're not exactly common. But getting that diagnosis right and early, well, it's crucial. Prompt immunotherapy can make a huge difference to outcomes, maybe even prevent permanent deficits.
Absolutely. And discovering these autoantibodies, the intracellular ones, the surface ones that really did change the game for diagnosis and management. Ordering these tests is just, standard practice now.
It is. But one of the sources uses this great phrase, the world beyond the lab slip. Because just ordering the test isn't the whole story. Not by a long shot. Accurate diagnosis, it depends on picking the right patient in the first place, choosing the most suitable assays. And then this is key, interpreting those results in the clinical context. And we have to remember, these commercial tests, they aren't perfect. They lack perfect sensitivity and specificity.
Okay, let's unpack that a bit. We're looking at two related articles here, both in neurology, neuroimmunology, and neuroinflammation. They basically put common, commercially available indirect immunofluorescence tissue-based assays, let's call them IIFTBAs, under the microscope. One study zeroed in on antibodies to intracellular antigens, the ICABs, sometimes called onconeural antibodies.
Right, the ICABs. And the other looked at antibodies targeting neuronal surface antigens, or NSABs.
Let's start with that first study on the intracellular antibodies, Milano and colleagues. The big question was, essentially, can you reliably use these commercial IFTBAs as your first screen for these ICABs?
Exactly. So they analyzed samples from 100 patients who were already confirmed positive for ICABs using other methods, like in-house tests and line blots or cell-based assays. Plus, they had 50 negative controls. Most were serum samples, 90 of them, but also 10 cerebrospinal fluid samples.
And they ran these samples using two common commercial IFTBAs.
That's right, kits from Inova and Autoimmune. And they were careful to follow the manufacturer's instructions to the letter. Specific dilutions for serum versus CSF.
Then who read the results?
They had a panel, 2 experienced raters and 3 less experienced ones. Critically, everyone was blinded to the true antibody status of the samples. Any disagreements between the experienced raters were discussed to reach a consensus.
Okay, so focusing on those experienced raters, sort of the best case scenario for reading these tests, what did they find?
Well, the overall performance. Inova correctly identified 79% of the samples, which means it misclassified 19%. Autoimmune came in a bit lower, correctly identifying 70%, meaning it misclassified 27%.
Okay, so let's break that down. Sensitivity first. How good were they at picking up the actual positives?
For Inova, the sensitivity was 73%.
73. So that means, what, 27% of patients who had the antibodies were missed? That's more than 1 in 4?
Precisely. A concerning false negative rate. And for Autoimmune, sensitivity was even lower, only 64%. So it missed 36% of the positive samples, over a third.
And what about specificity? How good were they at correctly identifying the negatives?
Specificity looked a bit better, but still not perfect. Inova had 96% specificity. That means 4% of the negative samples were wrongly flagged as positive, false positives. Autoimmune had 88% specificity, so 12% false positives there.
So you've got significant issues with both missing true positives and incorrectly flagging negatives.
Exactly. Both types of errors were happening at substantial rates.
Did performance vary depending on the specific antibody?
Oh, very much so. And this is where it gets particularly worrying for clinical practice. Both kits struggled with sensitivity for CV2, SOX1, and amphiphysin antibodies, just didn't pick them up reliably. And then look at Me2 antibodies. Inova detected 9 out of 10 positive samples. Pretty good. But Autoimmune, only 1 out of 10.
Only 1? That's a huge difference.
Huge. And it went the other way for Huri antibodies. Autoimmune found 19 out of 20, very sensitive. But Inova only found 12 out of 20. There was even one case, a CV2 positive sample, that Autoimmune did detect as positive, but it was misidentified as GAD65.
That misidentification sounds critical. Was pattern recognition generally difficult?
Yes. That was another major finding. Recognizing the antibody-specific staining patterns on the tissue sections proved challenging. Even among the positive samples that were detected, the correct specific pattern was only identified 62% of the time with INOVA and just 55% with Euroimmune.
Wow. So almost half the time, even if the test was positive, the specific pattern wasn't right.
Exactly, which has obvious implications for deciding which antibody it might be.
And I remember the study mentioning issues with nonspecific staining in the controls too, things that looked positive but weren't.
Absolutely. This is a huge potential pitfall leading to false positives. They found various nonspecific patterns in the negative control samples that could easily mimic true antibody staining.
Yeah.
Things like neurofilament-like staining that showed up in up to 22% of controls of the Euroimmune kit, blood vessel staining at up to 18% with INOVA, and perhaps most concerningly, amphiphysin-like staining was seen in up to 26% of negative controls with Euroimmune.
Amphiphysin-like staining in over a quarter of negatives. That sounds like a recipe for misdiagnosis.
It really does. Especially because, as we'll discuss, amphiphysin has very specific clinical implications. These non-specific patterns are easily misinterpreted, particularly if the person reading the slide isn't highly experienced.
Which brings us to the less experienced raters. How did they fare?
Well, as you might expect, their results showed significantly higher rates of false positives compared to the experienced group. With the Euroimmune test, the false positive rate went up to 22% for the less experienced readers. Remember, it was 4 to 12% for the experienced ones.
So double or even more than triple the false positive rate.
Yes, it really highlights that reading these complex tissue patterns accurately isn't simple. It takes considerable expertise.
No, the editorial also touched upon the companion study, the one looking at commercial IR-TBAs for the surface antibodies, the NSABs. Were the findings similar there?
Broadly, yes. Performance issues were seen there too. That study involved nearly 200 patient samples and about 100 negative controls. And it found that sensitivity for these commercial tissue-based assays for surface antibodies was, well, modest, in the range of 76 to 84%.
Still missing a significant chunk of positives then.
Yes. And false positives were an issue too, with specificity only around 72 to 73%.
Huh.
The editorial specifically pointed out that for some of these assays, in certain scenarios, they could miss up to half of the NMDAR antibody-positive cases.
Half. That's quite concerning for such a well-known antibody.
It is. So the overall picture, whether looking at intracellular or surface antibodies, is that these commercial tissue-based assays have real limitations.
Okay, let's really translate this data now. What does this mean for you, the practicing neurologist, when you order these tests, when you get the results back?
I think the core message, the really critical takeaway from this research, is that commercial IFEBAs, used alone, have suboptimal diagnostic performance for both ICABs and NSABs. Relying solely on them is risky.
And those risks have very real consequences for patient care.
Absolutely. First, the high false negative rates. We're talking 25 to 35% potentially missed for intracellular antibodies if you only use these commercial tissue assays for screening. That's potentially missing a diagnosis that could respond dramatically to immunotherapy.
And the misclassification issue seems just as dangerous.
It can be. Mistaking one pattern for another, like that amphiphysin versus GAD65 example, it leads you down completely different clinical pathways. Remember, amphiphysin antibodies mean a high cancer risk. Over 70% of patients have cancer. So you need diligent, repeated screening, maybe every 6 months, if the first look is negative.
Whereas GAD65 has a low cancer risk.
Much lower. Repeated extensive screening isn't typically recommended, so getting that antibody identification wrong directly impacts your whole management plan, your counseling, everything.
And then there are the false positives, triggering potentially unnecessary workups.
Precisely. Those nonspecific staining patterns, especially if interpreted by someone less experienced, can trigger a cascade of unnecessary tests. You might order CT scans, PET scans, lumbar punctures, brain MRIs, all based on a false lead from the antibody test. That's not just costly. It subjects the patient to procedures they don't need, causes anxiety, and critically, it can delay finding the real diagnosis.
So, given all these significant limitations, what's the practical advice? What should neurologists be doing differently?
Well, the clearest recommendation is this. Do not use these commercial indirect immunofluorescence tissue-based assays as your sole screening strategy, not for intracellular antibodies and not for surface antibodies.
So what should be done instead?
For intracellular antibodies, the evidence points towards combining the commercial tissue assay with more specific confirmatory tests, things like line blots or cell-based assays. For neuronal surface antibodies, commercially available cell-based assays are generally considered a better approach. And it's really important to test both CSF and serum when you suspect these.
It sounds like knowing the specifics of what your local lab does is really key here.
It's paramount. You need to know exactly which test system they're using. Ask the lab. Are they just using the tissue-based assay for screening, or do they automatically follow up suspicious or positive screens with confirmatory tests? Which ones? And you really need to read the fine print on those lab reports. Understand the stated limitations of the test that was performed.
And what if the commercial test is negative, but you still strongly suspect an autoimmune cause?
That's a crucial point. If your clinical suspicion remains high, despite negative or maybe confusing results from standard commercial tests, you should seriously consider retesting, preferably by sending samples to a specialized reference center. These centers often have highly validated in-house assays or specialized platforms with better characterized performance. And maybe one of the most important things, talk to your lab colleagues. Engage in proactive communication with the immunologists or laboratory scientists running these tests. They can provide invaluable context.
Good points. We should also briefly mention the limitations of the main ICAB study itself, right?
Yes, definitely important for context. It was done in a single lab, so generalizability might be somewhat limited. They also stuck strictly to the manufacturer's recommended dilutions. Maybe different dilutions would perform differently, though that wasn't tested. They used a fixed number of samples per antibody type, not reflecting real-world prevalence. Also, the positive samples came from patients who already had pretty clear syndromes, which might potentially inflate the perceived performance compared to using the test in a less selected population.
And fewer negative controls than positive ones.
Right, which makes the specificity estimates perhaps a little less robust than the sensitivity ones. Still, the overall trends are quite clear despite these limitations.
So wrapping this up, this deep dive really hammers home the need to look beyond the lab slip. Relying just on that positive or negative result from a commercial tissue-based assay for neuronal antibodies, well, it's fraught with potential errors.
Both false negatives, missing diagnoses, and false positives, leading to unnecessary workups and delays. Both can significantly impact patient care.
It really makes you think.
It does. And it raises a broader question for all of us in the field, doesn't it? As our understanding of these tests and the underlying biology evolves, how do we make sure our clinical practice, how we order tests, how we interpret them keeps pace, and what's the role of that direct ongoing communication between clinicians on the front lines and the experts in the laboratory in making sure we get the diagnosis right for our patients?
That's definitely something important for us all to consider. We've covered the key findings and the crucial clinical implications from these important studies on commercial tissue-based antibody assays. Remember, this has been a summary. For all the nuances and full details, we strongly encourage you to read the full papers yourselves.